So firstly, thank you everybody for joining us this morning, and thank you to our panelists. I will get to introduce you in a few moments. And welcome to the Mail and Guardian and United Nations Population Fund webinar in collaboration with the Commission on Gender Equality under the leadership of the United Nations representative, Ms. Beatrice Mutali. And today we are marking International Day of the Midwife 2020. Now, every year, the International Day of the Midwife honors the life saving work of midwives, the support they provide pregnant women, mothers, newborn children all over the world, including in resource challenged settings. The scaled up investments in quality midwifery care are central to achieving the Health Sustainable Development Goals, eliminating maternal and newborn mortality and morbidity, and ensuring that universal access to sexual and reproductive health and rights is realized. When midwives are educated to international standards, and midwifery includes the provision of family planning, it could avert more than 80% of all maternal deaths, stillbirths, and neonatal deaths. Achieving this important impact, it also requires that midwives are licensed, regulated, but fully integrated into health systems and working in interprofessional team. And this we know is a WHO's 2020 assertions. And we also know that 30 million women do not give birth in a health facility. This is important. 45 million women get inadequate antenatal care support. 200 million women face an unmet need for contraception. And there are about 25 million unsafe abortions globally. 350 million women and men need treatment for one or four curable STIs. And there are 2 million new HIV infections. Investments in quality midwifery care are essential to address all these gaps. And these statistics I've been sharing with you are coming from the Lancet in 2015. Now, this year's theme set by the International Confederation of Midwives is Midwives Celebrate, Demonstrate, Mobilize, and Unite. And I think this is a very important theme given what has happened globally with the recent COVID-19 pandemic. Celebrate, demonstrate, mobilize, and unite. And like all healthcare workers, midwives on the front lines are working 24 hours a day, often at a great risk to their own health and safety. And so, as the lessons of COVID-19 are teaching us, we need a much greater investment in midwifery under the universal health coverage, and midwives must be empowered to deliver their services all the more support that is ultimately grounded in gender equality and human rights. And so I'm Dr. Tlaleng Mofokeng, and I'm a commissioner at the Commission for Gender Equality. The CGE is a constitutional entity which is relied upon in South Africa to strengthen the constitutional democracy. And I'm on the education and research and communications, as well as the strategic planning committees. I have a medical degree from the University of KwaZulu-Natal, and I've been working in sexual and reproductive health and rights. And I will be your moderator for this webinar this morning. I also have on the panel Dr. Manu Abdullah. She's a health systems specialist working for the UNFPA in the East and the Southern Africa region. Dr. Manu is also a medical doctor with a Master's of Arts in Population and Development from the Netherlands. She has provided technical support to the countries in the East and Southern Africa in health systems strengthening for sexual reproductive health, focusing on maternal health, generating and utilizing evidence and data, particularly on emergency obstetric care, maternal death surveillance, and response. We also have on the panel Elgonda Becker. She is the founder and the president for the Society of Midwives of South Africa from 2015 to present. With a long-standing role in the executive committee of SOMSA, Elgonda was a member of the organizing committee and scientific committee for the 25th Triennial International Confederation of Midwives in 2011. And she completed her first young women midwifery leadership program. She also serves as the member of the South African National Committee on Confidential Inquiries into Maternal Deaths, and her clinical midwifery experience is more than 25 years in normal low-risk care, high-risk care, as well as an independent midwife. And the last panelist is Dr. Melinda Rashad, and she's the head of Center for Vaccines and Immunology at the National Institute for Communicable Diseases, with a joint appointment to the Chemical Pathology Department at Wits University. She obtained her medical degree from the University of the Witwatersrand, followed by a specialist qualification in clinical pathology from the College of Medicine in South Africa. Thank you very much for all of you for joining us this morning to celebrate a very important occasion, celebrating midwives and the role they play in society. So before we go on into the actual conversation, I would like to offer you each an opportunity to introduce yourselves and make your opening remarks. And so I will start with you, Manu. You may go ahead.
Thank you very much, Dr. Tlang. And like mentioned, I work for UNFPA, Eastern Southern Africa Regional Office, based in Johannesburg. Before I joined UNFPA ESA, I used to work with Ethiopia UNFPA country office. So I will be blending my experience from Ethiopia as well as from the regional office in Eastern Southern Africa, which we work with 23 countries in the region. Thank you.
Thank you very much. Elgonda?
Good morning. Thank you very much for having us as midwives as part of this panel. Yes, my day job is basically education of midwives, but I am very passionate about the bigger strengthening of the profession, because we believe that midwives indeed are able to do what they need to do, as you have correctly said, if they are educated and licensed according to the global standards. But I also acknowledge that the profession lie very strong on a sound education basis, proper regulation, but also professional associations to voice the concerns of the midwives on the ground. So indeed, thank you for the opportunity to celebrate this. I might just add that actually our birthday or International Day was on the 5th, but still it is within this week that we are celebrating. So we also celebrate, as you know, this year, the Year of the Midwife and the Nurse. In some circles, it's even extended to say it might be the decade of these professions. We never knew that our celebrations this year would be in this very unique circumstances with the pandemic as it is. So even more so, it gives the opportunity to have these discussions, for which we are grateful.
Thank you very much for joining us, Elgonda. And Melinda?
Thank you very much for having me on this important discussion. It's been a long time since my years in labour ward, but I spent a good chunk of time in my community service years in obstetrics, and it's left me with a very healthy respect for midwives and the midwifery profession. And I hope to be able to contribute to this panel. And I think we really need to air out issues that are for discussion, so many topical issues as COVID is upon us. And I think forearmed is forewarned, and having the conversations is very important.
Thank you very much, Melinda. And I mean, the issue of, midwives, falls directly within the issue of human rights, right? The fact that, people have human rights to accessing healthcare. And in South Africa's constitution, it goes even further to say, rights to accessing basic health, including reproductive health. So, these conversations are happening within that framework, a very important framework, I think, for all of us to be coming from. Because often, even as a clinician, we know a lot of sexual and reproductive health issues are often seen within health systems as things that can wait, And so in this time of COVID, we know globally and as well as regionally, there have been some movements by governments to reiterate and affirm the fact that sexual and reproductive health rights, the access is essential service, even within the disaster time or the time of this global pandemic of COVID. Now, Manu, in terms of your work in health systems training, what does it mean when you have a global disaster such as this one, where the risk though is that midwifery services, sexual and reproductive health services are going to be downscaled and sometimes be, not as prioritized as they should be normally? And what are the things that we could be looking forward to in this time? And perhaps UNFPA, if there's anything in terms of your oversight and monitoring that has coming through.
Yes, thank you very much. That's very correct. We have seen historically, whenever a crisis happened, the health system will not respond in the same way as the normal situation. We have seen it in many countries in our region, which has been affected by different outbreaks, and Ebola is one example. And during these outbreaks, always, unless we have earlier warning and preparation ahead of time, the health system, the routine health services will be compromised. And when it comes to maternal and newborn health services, these are the group which would be bearing the majority of the consequences when a health system is compromised. And but with this coronavirus, there was an early preparation. There was a lot of guidance from a global level. WHO has issued a guidance on continuity of essential services, apart from diagnosing and treatment of coronavirus. There are many pillars which we need to prepare to make sure that services continue, even if the health facilities are pressured by managing coronavirus. And many countries in our region, they have gone ahead in issuing many guidances and scope of work and so on, and also training their health workers on how to respond during this coronavirus when it comes to the routine maternal and newborn health services. At the regional level, what we have been working is together with WHO regional office and UNICEF regional office to bring together all these global guidances and contextualize it to our region, to our Africa region, and then support knowledge sharing between countries. And South Africa has been one of the countries that has been affected early in this outbreak. And we have learned also a lot from South Africa, and other countries like Kenya, Uganda, Ethiopia also are one of the early adopters of this continuity of essential services. And at regional level, we facilitate knowledge sharing, facilitate what has been in place and what are the challenges and bottlenecks, and how these challenges and bottlenecks has been surpassed by these countries. But still a huge problem is remaining, a huge gap is remaining, particularly at the initial phase of country response to COVID, which includes lockdowns, which imposes in some countries curfews, have affected, actually claimed many lives of women and their newborns, but countries are learning from them and improving it. And partnership, I think, is key to this. No one organization can do on its own. It's all about joining hands with midwives, with midwifery associations in countries are playing really a key role in ensuring that women get the services whenever they need it. And the truth is, pregnancy happens and delivery continue to happen. And making sure that women continue to receive the same respectful, dignified services is the center of our work. And what remains as a big issue is translating these guidances into actual implementation. That remains really a joint effort by every actor in this effort. We need to make sure that the community's feedback is received. Women who are delivering in health facilities, their voices are heard and their concerns have been addressed, so that the next woman who comes to the health facility will not face the same problem that has faced the woman before. Over to you. Thank you.
Yeah, thank you very much for that, Manu. And as you were speaking about some of the regulations in terms of lockdown, we know in South Africa there is limitation in terms of mobility, but there's also limitations in terms of public transportation that many pregnant women rely on, firstly for antenatal care, and of course for the time of delivery, which is very sensitive period in terms of delays. And I know that everyone has been focused on safe delivery, but we still have women who need to access, hospitals and clinics for antenatal care. And that can be a much longer period than the day of the delivery itself. And I want to bring you, Algonda, onto this point. We know that midwives are essential workforce, right? There is no way that we can achieve the sustainable development goals without paying attention to the work and the role of midwives. And being the backbone of healthy families and communities and health systems globally, what are some of the challenges that for you have existed all along? And COVID is really just heightening some of those challenges. And how have you, in your own way, in your own, innovative way, solved some of these issues? And I know for some of us in lower resource settings, the issues really were existing as structural fault lines way before COVID. Can you share with us from your experience at the moment what's coming through?
Yes, thank you. Indeed, you have started at the right spot to say that maternal child health is essentially founded on human rights. And I think the gender inequality that we see in society, despite having the most progressive constitution regarding that, is still a reality. There's many examples of that, both for the woman seeking care, but also for the midwifery staff complement that are predominantly women, firstly, but also because they serve women, it is seen as, is this so important as all the other big things like ICU care, for example, at the stage? So I think some of the challenges would be to safeguard the midwifery staff complement. Fortunately, within South Africa, that was done very quickly within the Department of Health. And from the Ministerial Committee, we indicated that this is essential services. The non-essential services within maternal child health were identified, and basically there's none of them within the continuum of childbearing that was identified, which is a very positive step, and indeed we also contributed to that. I think if I need to say what's the biggest long-term challenge that the midwifery profession that have to deal with not only COVID and pregnancy, but the normal continuum of the childbearing years, which start with a girl child and end at menopause. If we look at what's the biggest challenge, I think it is still that within South Africa, we do not have an independent, autonomous midwifery profession. It is still regulated under the Nursing Council, and everyone think that a nurse equals a midwife in South Africa. And if we look at the situation around COVID now, that's essentially the biggest danger, because then, since the majority of us, myself included, have a basic nursing qualification, you might then be called up to the higher service of nursing, and we might get to the place, but the women are just having normal births. But fortunately, as I've said, that gate have been closed formally. But what we see at this stage is that all the ills that have existed beforehand, as you've correctly said, just manifest themselves nicely now. So managers in lower positions might just change whatever the national directive was. One example, many years ago, I think 2015 already, if I now am not mistaken, there was a directive from the National Department of Health that staff working in maternity areas should not be rotated through the rest of the hospital, because there's a very certain set of competencies that we expect, and you want this to actually grow in a person. Because we all know that the day we got our qualifications, we basically knew the basics. But as you engage within your field, you get more competent, and especially clinical competence. So we still saw that individual managers would just ignore the national protocol, and they would, based on their own ideas, do things. So I think that is still a concern. We see that playing out in a number of ways at this stage. The provision of PPEs is one of them. Or just yesterday, I got the knowledge of a private hospital that stopped a service that women wanted, um, with very clear evidence backing of delayed cord clamping during a cesarean section, early skin-to-skin contact, which are all principles that we know from evidence and current policies, international and national, should be done. Where the people facilitating this for mothers getting a cesarean section were just removed from that service because it's not essential. So if the well-being and the positive experience with evidence that we know is beneficial to mother and baby is non-essential, we get to a very dangerous place. My bigger question to a facility like that would be, but why are you not providing what mothers need? And I think if we look at the theme of the International Confederation of Midwives, the one area of let us unite is really that it's imperative that midwives need to unite with women to say, but this is what women want. Can we please provide that? And I think that is basically for me, well, there's many things in the theme, the part of celebration, all the gains that we've seen. And I think within the whole reduction of maternal deaths that we have seen, I do celebrate each mother that do not succumb to complications or death because she's having a baby. But I think this thing of gender equality is probably within the next decade the biggest thing that we as a profession need to address with the women that need to have the babies in this time. I also voice what Dr. Muna have said about the mothers that already gave birth in this time. All gave stories. There's a number of research just jumping out on this as well. Apart now from the fact that they are scared about this whole impact on this new born baby of theirs, the disruption of the right to a birth companion is very rife. And as midwives, we need to protect that on many levels where we look at policy development. The issue around breastfeeding, a big issue around should the mother breastfeed with a mask, yes or no? And we know if she is at all at risk of transmitting anything to the baby, that is true. But there was at one stage people would say, oh, but then it's safer not to breastfeed. Oh, and then we go mad. So I think the bigger issue is that in healthcare, especially from a bigger level of administration and management, what women want is never regarded. And this is the time that we could say, but let us not now. I do respect that we need to work very safely because we do not want to create the opportunity for the spread of the disease. But there's certain things that should be non-negotiable. And in a way, we have the opportunity to make sure that those are still happening despite the time that we are in, make sure that it is done safely for the community's sake, of course, but that we indeed can get to a place to respect everyone's right, the mother's right to have a companion safely there, the mother's right to access services, to get to the service, the transport to get her there. I think it's a well-known stumbling block all along, but now it's even worse. And with all the gains of programs like Bank Plus with more antenatal visits because we need to reduce hypertensive deaths in South Africa. If we go back to losing the gains that we've had in the past 2 years, we might see a rise in maternal deaths, which none of us want. So indeed, this I don't think it will ever stop, but this theme of this year, to unite with mothers, to get to a place where we can really give to mothers what they need and not what we think they should get, is the challenge for the bigger health system.
Thank you, Algonda. Melinda, I think this one for you, we're going to lean on you a lot for the COVID, information. We all hearing the numbers every day. Various health ministries, are giving us the statistics for new infections. And I think for you, I would like you to speak to the occupational risk for midwives, right, in the performance of their job. You know, it's like the aeroplane. Before you can put a mask on anyone else's face, you put it on yourself. And if you want, midwifery and midwives who are safe and able to offer quality care, they need to be taken care of. And so some of the anxieties, I suppose, are coming from the fact that people don't have PPE, but also what is required? How can midwives, out of their own accord, take their own health and safety into their own hands? So what are some of the things that midwives can do occupationally while they are at work to reduce the risk of COVID-19?
So thank you for that. I think the first thing to really discuss and make sure everyone is on the same page about is the fact that this virus is not going away anytime soon. It's not going to disappear within the next 3 or 4 weeks, or probably even within the next 3 or 4 months. Flattening the curve also has the effect of extending the curve. And as we've been successful in flattening the curve so far, really what we will likely see is a prolongation of our epidemic. So fewer cases happening all at the same time, but more cases spread out over time, because this is not an epidemic that we can eliminate. It's not something that we can chase and control and completely quarantine so that there are no further cases. That is not a realistic expectation at this point in time. So we are expecting the epidemic to spread. We are just hoping that it spreads slowly and at a controlled rate, so that no particular aspect of the health system is overwhelmed at any one time. So this is something that is going to be with us for the near future, for the foreseeable future, and we really need to learn to work with it. We are not, unfortunately, going to be able to, pull the blankets over our heads and hope it goes away. That's unfortunately not how it's going to pan out. So in terms of occupational preparedness, I think really planning and arming ourselves with knowledge is the important thing. People who are insecure and scared, midwives who are insecure and scared, are likely to take out that insecurity on their patients and on their families and on their staff, and not be confident and relaxed in dealing with the facts at hand. So I think it's important for every midwife to arm themselves with facts and information, and to fully prepare themselves so that they can feel confident and comfortable in carrying out their daily duties and their daily tasks. So as with any workplace, and particularly any health worker setting, there are particular considerations for the workplace. Before we get on to the discussion of PPE, I just want to remind everybody that the occupational safety really is, they showed pictures of a pyramid, and PPE is the top little section of the pyramid. And really most of the gains that are made in that pyramid come from administrative controls sitting at the bottom of the pyramid, which means limiting the number of infected people coming into our facilities. And for example, by things like working out, what the schedule of our appointments be? Can we reschedule certain appointments to be at longer intervals if visits are not essential? Can we perhaps schedule appointments at certain times so that our waiting rooms are not full of women or who find it difficult to social distance from each other? So things like really taking stock of our practices, our everyday practices and our everyday procedures can go a long way into minimizing the influx of potentially infected people into our workplace. So administrative controls are very important, and really everyone should look at their own workplace and at their own institution to see how best can they come up with creative ways of just lessening the risk every day in that workplace. The second part to think about is that PPE and the usage of PPE needs to be consistent. It's not something that someone should get very stressed about because now there is a patient who is coughing and who is feverish, and now suddenly there's a panic. Oh, where's my mask? Where's my glove? PPE, as we've learned from the HIV world, needs to be applied consistently in the same way we apply universal precautions. So it's up to every health worker to know what it is that they are going to wear every day, dealing with every patient, and then to wear it and practice it consistently. So in most of our facilities, that's universal masking for health workers. So it's putting on a mask, as you'll be wearing a mask now, because a mask is mandatory even in the public setting. So you should be wearing a mask on your public transport, a cloth mask before you even get to work. When you get to work, you should put on your surgical mask, and it should be on until the end of your shift. As you are dealing with women, we know that some women are asymptomatic, even if they have COVID. So our precautions should not only be when we think we have a patient under investigation or a confirmed COVID case. They should be for all women, and things that are realistic and practical to practice consistently every single day. And particularly in the midwifery setting, where we are used to close contact with our patients, touching and feeling and so on, really it's around attention to hand washing after every patient contact, trying to maintain a distance of 1.5 to 2 meters from patients unless contact is essential. Really being aware of any contact so that we can practice the hand hygiene before and after, including with mom and with baby, and being very aware of transmission patterns and what our defense mechanisms are in dealing with those transmission risks.
Okay, thank you, Melinda. And in fact, you've just reminded me now, speaking about overcrowding, the fact that in Gauteng, there was a news report regarding one of the hospitals and the crowding in the maternity ward. I think it was the postnatal ward, and how, the issues of overcrowding, as much as COVID is making them worse, those issues have existed before COVID. And we mustn't forget all the innovation to solve some of these problems, because we need them to carry on even after COVID, because we've seen how governments can suddenly be very responsive to some of these issues. And so we should hold them to this higher standard, I think. Manu, just in terms of your programs and your involvement in terms of community level, I mean, we know that the right to make decisions about one's fertility, it's a human right, to have a healthy, fulfilling life. Women have to have these basic rights respected. And of course, hand in hand with that is the right to accurate information. And often in some countries, the legal framework is such that some of these, services are criminalized, and some of the choices are criminalized. And what type of programs can you share with us that you've been involved with in the regions that you are, whether it's about information giving, incorporating the youth, to be more active and be ambassadors and champions in SRHR, because I mean, a lot of human rights, hinge on sexual and reproductive health. I'm just thinking of the right, to freedom from torture, right to health, right to privacy, freedom and the right to be free from discrimination. How are you, through your programs, getting through information to women so they can advocate for themselves? Because we can't often, or at least assume, that all governments everywhere respect these rights. So we need to have, young people and women knowing about their own rights to advocate for themselves.
Yes, thank you for that question. And UNFPA upholds the universal rights, which includes the right to have access to health services and informations. And in UNFPA, I think we have a broad program that brings together from the early childhood stage. And we, as you say, young people are our center of partner. And human rights, it starts from early treatment of boys and women differently from a family. And we empower families we empower women to recognize this. And when it comes to sexual reproductive health, we support in a number of countries comprehensive sexual education, which in many countries have welcomed and incorporated into curriculums, usually high schools, and some of them even in primary schools. And we have young people, we empower young people. We have a network we have a whole team working with young people and empowering young people, and creating an opportunity for them to participate and make decisions when it comes to programs or policies that are put in place for young people, and they are very vocal. They have said clearly that policies and programs that have been put in place on behalf of young people by older people are not really usually useful. So UNFPA, we create that opportunity, bringing them to the table, and it's been fruitful. There are quite a number of policies, even legal framework that has been revised from different countries based on this advocacy effort by Young People's Network across the region. But as you say, it remains a challenge. It's not an easy task to do. Some countries, they have their own justification and rationale and whatever policy put in place, and that has to be done gradually, along with other partners like the regional economic communities, which countries work closely. And UNFPA, we work closely with governments as well. It's a one unit working together for a betterment of the citizens. One thing I have noticed in my work is we can address a policy issue from different directions. And it doesn't have to be really face to face, like I'm saying this and you are saying this, and you have to come to terms. Like, we can address it in different ways. One example to give you is on abortion. Abortion have been a very contested issue, as you know, by many countries, and in our region, when you see the legal framework of abortion, some countries have been progressed and has become liberalized, but most of countries in our region, their legal framework is very restrictive that limits to save the life of the woman, or to when incest happen, or if the baby has some kind of genetic problem, when a rape happen, and so on. But only few countries, I think only 2 countries, if I'm not mistaken, it's only South Africa and Angola, I think, that allows on demand. If a woman doesn't want to carry on the pregnancy, she can ask for abortion, and she is allowed. This is just a legal framework. There is also all kinds of limitation when it comes to provision of the services. So one thing I have observed is when you talk to the governments about the consequence of unsafe abortion, how many lives unsafe abortion is claiming, it's very easier to come into terms and to make sensible decisions. Even if we don't have to change the legal framework, we can fix a few administrative things that can allow women to practice their right. So it depends. From what I can say is, it depends on how we really address the issue, and coming together. It's not like one part pushing for a certain agenda, but coming together, and we are all here to serve humanity, to make sure that people have practiced their right to health.
Thanks, Manu. And at the Commission on Gender Equality, we have a toll-free number where people can, put in their complaints, or if they have any issues with access. And the issue of accessing, a timely and safe abortion remains one of the themes, that are coming through, even through our complaints line. And it's fascinating how you can have a legal framework that's affirming of rights and services, and yet in practice, they remain unchanged, or at least inaccessible. And part of that is around the stigma and the attitude, that goes with some of these services around SRHR. But at the end of the day, the fact is, when a woman has decided she can't carry a pregnancy term, that's a decision she made. And what we are trying to do is make sure that services are safe, and not even so much that we have to wait for legal framework. There's still so much that can be done despite a legal framework, despite restrictions, to ensure that services are safe. And I think that's where healthcare professionals can really step up their game here, in terms of advocating for our patients, because we know the death and the morbidity, the comorbidities that come, and the cost to health systems. It is still much cost effective to the health system budget to offer a safe medical abortion in the first trimester than to deal with the complication of a second trimester that's done outside of a health facility, with ICU or high care services. But anyway, that's just one example, right, of how legal frameworks can impact access. And Elgonda, with you are a trainer. You are in charge of assisting the new crop, of midwives. And I know it's something that you are personally passionate about because you are reading for your own PhD. But also just in terms of how you are assisting young people in this time to be able to not be completely disconnected from their curriculum. How are you keeping in touch with your students? And are you being innovative in some way? Or has COVID completely thrown out your academic year in terms of your training?
COVID is very busy on all campuses, so to disrupt whatever is taking place. But yeah, we are hoping to get students, especially, midwifery is generally offered in the later years of study. So for the students that need to qualify at this stage, it's quite imperative to get back to clinical practice because they won't reach their outcomes or the required competencies that they need to reach. I think, but you open a can of worms every time when you ask a question, because when we look at the issues of the profession, I've mentioned that midwifery is regulated under the Nursing Council at this stage. And very early in the pandemic, we added the Nursing Council to our concerns because you need to understand in education that there's two ways of getting through this. If it was history or any other non-clinical subject, it's very easy to go to online platforms, and indeed that is what we are busy with at our own facility. So there's wonderful ways, and you can engage students in new, innovative ways on student management platforms. So there's many things that can happen online. But to really get a midwife that has competence, which is the knowledge, but also the psychomotor skill to do something, but the professional behavior, as Muna has said, the respectful care principles, need them to be there with the woman. They need to be in a clinical situation. We all know that when you are getting theoretical knowledge, there's a component, but it all clicks, and the real education actually happens where you engage with women. So definitely that need is there. But the very Nursing Council had a very quick announcement to say that their offices are closed, they are working remotely, and they are not considering anything. Students need to do whatever they need to do before the end of the year and be ready for ComServe placement. So I think that creates a lot of frustration currently with a lot of educators to say that it's not business as usual. We also have at the moment in our profession move to a new curriculum. The latest intake this year in the graduate programs were taken into the new qualification, but the old ones are phasing out, and there's certain programs where the students are phasing out now and they won't be able to reach their outcomes. So the silence on important matters is a long-standing problem that we do see. But I must say it opens new avenues of really encouraging deep learning, really taking students to engage with content that you usually won't have time with. But we know that this time that we are gaining is lost on another level. So the panic around that is real for students, but also now for us that need to know that, this need to happen. But I think the students have voiced also to us a dual concern. One is similar to ours, that, you're getting behind with what should happen. But then similarly, this thing of am I safe? And I think this is where Melinda also said that, we tried to say, but these things. We know that you can keep yourself safe by doing these things. So I think they are more settled around that. But still, they are young professionals. What we also see is with the PPE war out there, that just the past week, I got messages from staff working in facilities where we place students that say each professional member of the team there get one surgical mask that they have to wear for a full week. So the limited availability of PPE out there might be another, it's another bridge that we need to cross, because then students who are not formal employees and are basically only doing their work integrated learning will definitely not get access to the limited stock that is available. So from education facilities, that brings up the next level of responsibility towards them.
Thank you, Algonda. I'm just going to go through the chat and just give you some feedback from the people who have joined us. Nolukanya says she'll always have a soft spot for midwives who assisted a successful vaginal birth after cesarean for one of her daughters. And people are just commenting on the relevance of this topic. And Portia is saying that access to sexual and reproductive health in rural and peri-urban areas in South Africa is a challenge. Is there any effort to address this? Linda is saying that reduced visits for antenatal care, depending on complications, could assist with COVID. Online consultations are recommended for avoiding crowding, although this can work mostly for private sector. What is the equivalent for the burdened public health sector, she says. And Keketso is saying nothing about us without us. Young people must be the center of policy engagement. And Nomtika is saying absolutely. Thanks for your points, Dr. Manu. And Matojo is saying that basic midwifery training should also include training on manual vacuum aspiration. And so that's just some of the comments of the people who are joining us on the webinar. And Melinda, in terms of COVID, the anxiety is there. That's the truth of the matter. We are just in the beginning stages of this. And I'm looking at our time. I would like us to start thinking about closing remarks so that we can wind down our conversation nicely. But in terms of the advice you can give to mothers, we've spoken about midwives and the occupational risk. Is there anything you can say about mothers and COVID-19 and their worries?
Right, so I think we need to be very sympathetic to mothers in this time. We know that pregnancy is very stressful at the best of time, and certainly now COVID adds an additional layer of stress and anxiety. So in the same way as midwives should prepare themselves, we need to tell mothers to prepare themselves with knowledge and understanding and knowing how to protect themselves. And they need to know how to protect themselves when they're out on the street via social distancing measures and masking and hand washing. And they also need, though, to have confidence in the service we are offering them. So they must know that it is essential for them to come to their antenatal visits. They must know that it's essential to take their babies for vaccinations. And these are things we should stress with them when we are talking to them. We should hear their concerns and we should engage with them and stress to them that antenatal care is an essential service, that they are entitled to it, and that they need to keep their appointments. And we should, in the same way, stress to them that their babies require vaccination and they need to ensure that vaccinations happen. We do need to, on our side, make sure that we can lead in our own environments to say that things are not going to be the same as they always were, and we are going to make these appointments as safe as we possibly can for the women. And this includes changing our usual practices in our antenatal clinics and in our immunization clinics. We really must lead in our own spheres, in our own space, in our own place, to say we can do it better. And I encourage people to lead in their own macro environment to say, I have an idea. Wouldn't it be better if we did it like this? We can have a dedicated staff member doing this function, someone who is completely different from people who are perhaps seeing the patients with upper respiratory tract infections, and we can keep our services as separate as possible. The other practical advice I have for mothers that I've just been discussing with my colleagues and friends in the last week is I would tell mothers that they should self-quarantine for 2 weeks before they're due. So from about 37 weeks, I would tell mothers to self-quarantine at home. Because if mothers catch COVID, I would rather them catch it somewhere early in their pregnancy or somewhere way after delivery when things have settled down and when things are calm. Really what we want to avoid is people catching COVID at the time when they need to come in for delivery and access the healthcare system. And then there is the risk of nosocomial spread, and there are difficulties with the breastfeeding and all these discussions around what to do and who to admit, and keeping mothers and babies together and separate and so on. So all these complications can be avoided if mothers do not catch COVID in the week or two before delivery. And I would like to strongly recommend, and I hope it will be discussed for future guidelines, I would like to recommend that mothers stop working by 37 weeks and self-quarantine at home, get their food delivered and so on, get people to help them so that they do not put themselves at risk in those critical 2 weeks before delivery.
It's so right, what you're saying, Melinda, because and the disparities, I think, in the private and public health sectors, get pronounced at this time. And I know a couple of private hospitals, are saying that women need 2 negative COVID tests for themselves as well as their birthing companion. And we know what this means in the public sector. We are already overwhelmed just with people who are at higher risk, never mind electively choosing, to have these 2 tests 48 hours apart, to gain access to the health facility. So it is an issue to watch out for. I think, especially for me, as my role as commissioner at CGE, over this time, it's important for all of us, to work together in terms of oversight and monitoring and be responsive, immediately, I think, and intervene where we know, that the stakes are high and lives will be lost. And I think this is one area for me personally, of maternal care and birthing. And especially even after, birth, that period, that 6-week period is critical. Mental health screening for women still needs to continue. Issues of breastfeeding and latching and nutrition and support, contraception support, all of this has to continue. And just in closing, if you can, Elgonda, maybe summarize what is your vision for the next year? COVID is here and it's not going to go away instantly. What is your vision and mission in terms of quality services to the community, your role as a trainer, as a teacher, but also a student, right, of the world and of the faculty, and what positives we can come out of this period of COVID, but also just in terms of institutions working together to defend, gender equality. And with you, Mani, as well, I would like you to speak a little bit to, the work around health systems training, around how can people draw on in terms of UNFPA and what can we come to you for in terms of an assistance. And Melinda, if you can share with us some of the contact details, if people want any more information about COVID-related issues, that will help us a lot as well. And so Manu, in your closing remarks, keep it short. We have about 7 minutes to go. What would you like to say before we close? Manu?
Thank you very much. I was waiting for Elgonda to start. Okay, so when it comes to health system, I think, from the lesson learned from other countries also, now is a time where the focus is on preparedness for COVID. A lot of focus is on mitigation and response for COVID. And it's very common to overlook what's required to provide the routine services like the services provided by midwives. So I think for me, midwives should be proactive in making sure that all the necessary supplies and medicines and equipments are ordered and, if possible, prepositioned for a longer period of time. Like it's been said, we are expecting COVID is not going to go away in a few weeks. So make sure that midwives have all these supplies and medicines they need for at least a few months, and proactively make sure that they are included in the national procurement plans. This is one. The other is service quality. I think, midwives can play a really big role to outshine, despite all this hardship and struggle, ensuring that women go out of the delivery room satisfied, happy, and say the words that what Midwives has done to them despite all this hardship. That's very important, I think. And it's very easy to lapse into, substandard care. And we have seen it everywhere. We have seen it, women come out of a delivery room and with so much disappointment during this COVID time. So Midwives, let's outshine. And we have seen it, we can do it. We have seen it in other humanitarian crises, and midwives are sometimes the only health professionals that stayed behind when others fled. And UNFPA is it's our major focus. We support midwives in terms of protecting them. Also, what's been said by Melinda. Also, we are there to protect, to connect you. Also, we are there to connect you across the region and have your voices exchange your concerns and doubts and fears and so on. This is UNFPA pays attention to. Thank you very much.
Thank you, Manuel Ganda.
Yes, I can indeed say that's true. UNFPA have been partnering with midwifery associations throughout the sub-region very effectively. And indeed, it is through partners like this that we actually get to your question, Tlolani, which is to really, if there's one thing that I think we should all work, or that we as midwives should work towards, is to strengthen the agency for the midwives, but also for the women, and to really allow women at this stage to take up what they need from a normal process of life that is still continuing. And I think within the next few years after COVID, with the socioeconomic challenges, but also the health challenges, we should never then get to a place where we see actually that gender inequality will rise up due to this. So I think the only mediation for that for me is agency, to give that back to women firstly, and secondly to the profession. I might just also say, if we look at the questions and the poll that we've seen on this whole webinar, I can only agree that basic midwifery training should indeed comply with global standards and with the essential competencies. And in all of that, MVA is definitely there. But as I've mentioned, our challenge in South Africa is that the profession is not regulated as a real autonomous profession. So yes, I think that if we can comply to this, we will cover all the other issues, like making sure that essential services are rendered, that women still have access to the basic care that they need, but that basic care will still be what women need and not what the system thinks that it should be looking like.
Exactly. Thank you so much, Elgonda. And for you, Melinda?
I would say there's two aspects that you should prepare yourselves in, the theory and the practice. So for the theory, there are great websites. You can look at the website of the NICD, the website of the South African Society of Obstetrics and Gynecology, where all the algorithms and suggestions are there for what you should do. And on the practical side, I would say please do simulations in your own workplace. Please do a simulation of a COVID positive patient presenting now about to deliver, of a patient under investigation whom you still need to test for COVID. All different scenarios of how mothers might present. Do the simulations and give yourselves confidence. And then do a simulation of a health worker who is infected with COVID. Work out who would have to be quarantined. All your contacts would have to be quarantined. Work out if your system would still be able to cope. And when you think through those practical issues, you may see how better to align your working teams so that you can have continuous workflow, even if one of your staff members and all their contacts need to be off work at the same time. So
thank you very much. Yeah, thank you very much for joining us this afternoon. It has really been an enlightening conversation. And just to thank everyone else who joined us on this webinar, and especially thank you, Mail and Guardian, and the United Nations Population Fund, as well as the Commission on Gender Equality. And thank you to the UN representative, Ms. Beatrice Mutali, whose this webinar happened under their support and leadership. And of course, we were marking International Day of the Midwife 2020, and the theme, of course, is Midwives. Celebrate, demonstrate, mobilize, and unite. And I hope this is a spirit we will take on further as all of us work to ensure gender equality and human rights are respected all over the world. Thank you so much, everyone, for joining us. And stay safe in this period.
Thank you.
Thank you.